Welcome to the Orthodontics in Conference podcast, where Farouk brings you the summary of key lectures from orthodontic conferences around the world, with your host, Farouk Ahmed.
Hello all, and welcome to day 2 of the AAO's virtual annual session podcast. Today we're going to be looking at a number of topics. We've got 15 lectures to cover. We're going to be going through Maxillary Skeletal Expansion, looking at TADS, seems to be a real theme of this year's conference, aligners as well, looking at the Carey Appliance this time with a couple of lectures dedicated to that. We're also going to see where digital orthodontics is currently and how the innovators are implementing it into their practice. Just to recap, the podcast is an opinion piece from myself and it may not be 100% accurate, although we try our very best to ensure that it is. The podcast is not endorsed by an institute or by a speaker and is my independent work and that of the Orthodontics in Summary team. It is not intended to override or replace the requirements clinicians have to be familiar with the relevant training and guidelines for treatment of patients. With that, terms and conditions aside, guys, I will see you at the end and we'll begin looking at the first lecture from day 2. And if you guys wish to fast forward to a particular lecture, if you see the description on the website www.orthoinsummary.com, you can click on the link and go to that specific lecture and see the notes associated with it. Hope you guys enjoy the podcast, and I'll see you at the end. This lecture is entitled Long-Term Evaluation of Class 3 Orthopedics with Skeletal Anchorage, and this was by Tung Nguyen. Now, Tung has been a proponent of skeletal anchorage, has done a significant amount of work with Hugo De Clerck looking at bone-anchored plates. Now, Tung started off by describing the envelope of discrepancy, the classic information from profit. And he advised that, well, now with the advent of bone and skeletal anchorage, the envelope of what's possible through orthodontic treatment and orthopedic change is now changing. He starts off by describing bone-anchored maxillary protraction. So what is it? Well, it's essentially 4 skeletal plates, which are transmucosal. There are 2 plates in the infrazygomatic area in the maxilla, and there are 2 plates in the mandible, and this is in between the lateral and canine region. And the idea is that these plates have elastic bands attached to them of around 250 grams of force, and it's usually for patients who are between the ages of 11 and 14. And it's a class 3 vector, and the idea is that Tung will overcorrect these patients in that age group. So how does it work? Well, Tung went on to mention that it's a maxillary protraction device, and Hugo De Clerck's paper in 2010 describes it. But what actually takes place when it comes to the numbers? Well, there is a study which describes that. When it comes to using bone-anchored maxillary protraction, we know that we get around about 58% of the correction of the class 3 due to maxillary protraction. So that's in the order of around 4 millimeters. And we also then get mandibular restraint for the remainder 42% of around about 2.5 millimeters. The total correction is around 6.5 millimeter mark. Now, what's interesting is when they look at the study, we can see that we also get some mid-face protraction as well. It's the entire mid-facial complex which moves forwards of around about 3 millimeters. So it isn't just maxillary protraction, it's mid-face protraction. Now, Tung went on to describe, well, how do these changes take place? He described that we get maxillary change taking place due to distraction at the maxillary sutures. But what's interesting, and Hugo De Clerck talks about this in his lecture a bit more, is the closure of the mandibular angle of around about 2.5 degrees. I mentioned that we are now starting to have orthopedic change to the mandible. He also described changes at the condyle as well, how there's a distal direction of growth of around about 3.5 millimeters and around about 2.5 millimeters at the condyle. But what does that mean? What's the implications of that? Well, the idea is that the growth of the mandible is being redirected, so we're getting less AP growth taking place with the mandible. Tung went on to describe the retention program. So once the correction has taken place, actually patients carry on wearing their class 3 elastics. They're monitored every 6 months, and sometimes they have to go back to wear, depending on their growth. There's a long-term study that Tung's now been engaged with, and it's around about 15 years of follow-up study, so really long-term data. They looked at CBCT data, pre-end of treatment and long-term setups. And what they found was that A point generally changed round about 0.6 millimeters, but there was a vertical change of around about 2 millimeters. B point advanced as well, but less so. And he mentioned how that when it comes to relapse taking place, it's usually mandibular prognathic changes that result in it. And from his experience, he now says that using bone-anchored maxillary protraction for him are for maxillary deficient cases. They're mild to moderate in their nature and more effective in younger patients. He's mentioned his failure rates are around about 12%, and he marks it as a successful treatment for Class 3 management. This lecture is entitled Growth Modulation by Class 2 and 3 Orthopedics by Hugo De Clerck. Hugo has very much been a pioneer in the use of bollard plates or bone-anchored maxillary protraction with his classic paper now from 2010. Hugo has recently produced a website dedicated to bone-anchored maxillary protraction entitled www.lesschin.com. It is a really good resource for both patients, orthodontists and surgeons. Now, Hugo mentions why he put this website together, and he mentioned the main reason for failures he finds is surgical insertion. So this was to give a really comprehensive guide to surgical colleagues as to how to carry out this treatment. And I think making that accessible and open is a fantastic contribution to this topic, but also orthodontics and the outlook to have to share information with colleagues. So Hugo describes the effects of bone-anchored maxillary protraction. We find we generally get protraction of the maxilla around about 5 millimeters coming from his studies. He also mentioned that there's been a variety of studies which looked at how this change takes place. And he mentioned it's mainly the zygomatico-frontal suture and the zygomatical-temporal suture which have distraction taking place. He described a rotational effect. Now, this is based upon changing bones and therefore there being a center of rotation associated with that movement. He gave a comparison of the Herbst appliance, how there's a posterior rotation of the maxilla, or clockwise rotation as I will call it, as the molars intrude, and that's Pancho's classic study from 2002. He said when it comes to bone-anchored maxillary protraction, there is an anterior rotation to the maxilla. This is due to the molars moving downwards in the maxilla, and therefore this counterclockwise rotation then takes place. And there are two other key changes that have been noticed as to how we get correction using bone-anchored maxillary protraction. We generally tend to focus on the condyle, Hugo mentioned. And before describing the changes at the condyle, Hugo described what normally takes place for a Class 3 case, and that is the condyle usually grows backwards. For Class 2, it's the opposite, and the condyle usually grows forwards. So when it comes to using bone-anchored maxillary protraction, what's been found is that the condyle changes so that the condyle grows forwards. So taking on an opposite direction to the classic Class 3 growth. And he went on to describe changes that take place at the gonial angle. And he said that this is something they observed when it came to looking at a massive number of metrics for the changes for using bone-anchored maxillary protraction. And what he found was that the gonial angle would reduce by around 4 degrees in these patients compared to patients who weren't having treatment. And this was an interesting finding. He went back to Enlow's classic studies, where they looked at the growth taking place in the mandible and showed that actually the mandible as it grows, changes take place throughout the entirety of the mandible to different degrees. And what he's mentioned here and hypothesized is that bone-anchored maxillary protraction has a restraining effect on the mandible, but it orthopedically changes that pattern of growth. We get closure of the gonial angle, we get less anterior-posterior changes as a consequence of this change, which I thought was a really interesting idea. He mentioned the timeline for Class 3 orthopedics. He said, well, now we understand we get maxillary changes as well as mandibular changes. So we can treat patients later on with this technique. Patients between the ages of 11 to 13 may now be applicable for this, if not even older, as mandibular growth continues through later on. He described Class 2 cases. There is, interestingly, little literature looking at gonial angle changes. He mentioned how there has been some studies looking at the Herbst appliance, but there doesn't appear to be any changes. Now, he hypothesized, if we are able to open the gonial angle in class 2 cases and redirect the growth taking place orthopedically, we may be able to reduce the class 2 component. I must confess now, this is the second time I've listened to Hugo's lecture. Previously, it was at the WFO conference. Now, it's a heavy lecture where he has massive amounts of content, and it's all great stuff. Hopefully, I've been able to do justice by summarizing his lecture. This lecture is entitled, When You Play the Games of Thrones, You Win or You Die. Is There a Middle Ground? This is by Carlos Flores-Mir. Now, Carlos's title doesn't give much away about the content, but it is based upon looking at class 3 early interceptive treatment. And that's the premise, is that can we do it, should we not do it, and is there a middle way to go around it? So his main idea was to describe the research based upon it and his clinical experience. He just started off with looking at wound systematic review from 2017, which looked at with the use of protraction in different components, we can get an improvement in the overjet of around 2.5 millimeters. We increased the A and B by 4 degrees, but this is only in the short term. He mentioned the long-term evidence is limited. He looked at specifically bone-anchored maxillary protraction. How looking at Carnell's study from 2021, the systematic review showed a 4-degree change in A and B. They looked at the long-term effects with protraction of the maxilla, and there was no difference whether rapid maxillary expansion was used or was not used. But what's interesting is that the long-term data suggests, at least, that there's only 2 degrees of changes to SNA. And actually, after 3 years, those changes that take place have usually diminished. The overjet improves by 2.5 millimeters long-term wise, however long-term there's a millimeter relapse. And Carlos questioned whether that was clinically significant. Now, Hugo spoke about his own clinical experience using skeletal anchorage in class 3 cases. So the case where he carried out skeletal maxillary protraction using temporary anchorage devices and also class 3 elastics. This patient went on to have TADs for distalization and 2 upper units removed as the patient grew. Now, the total treatment time was over 97 months. And he described when he asked the patient, was it worth it to get their result? They said no, they'd have preferred to have had surgery. Now, although this was a success when it came to the clinical outcomes, Carlos asked the patient, was it worth it for them? And they said it wasn't. They would have preferred something else. So Carlos says, well, we can do treatment, but it doesn't mean that it's in the patient's best interest and improves their quality of life. Carlos's conclusion is that there is still uncertainty around class 3 correction long term. What we should do is have a continuous consent process with our patients and reassess after 6 months and see if patients are still willing to carry out those treatments with that level of uncertainty. I thought it was a great lecture where Carlos objectively assessed the literature based on the topic and also his clinical experience, but also concluded with the question, although we can clinically do something, is it actually beneficial for the patients? And we should be putting patients in the centre of the decision, especially on a topic as class 3 orthopedic change, where there are clearly grey areas as to what will predictably happen to patients. I thought it was a wonderful lecture and a great speaker. This lecture is entitled, Can Changing the Transverse Dimensions Improve the Quality of Orthodontic Treatment in Children? This is by Roberta Lione. So Roberta started off by describing malocclusion as not a disease, but rather a set of dental deviations, which sometimes can influence the quality of life. Now, there has been some but brief literature looking at rapid maxillary expansion and it's improving the quality of life. That was from McNamara in 2015. So she described what are the effects of a narrow maxilla. Well, we find patients have facial changes. They tend to have an underdeveloped midface, narrow pharyngeal airway, increased nasal resistance, and tend to be mouth breathers. Now, she related those same features for patients who also present with an anterior open bite. They have that narrow maxilla, But also the palatal morphology in anterior open bite cases is different. That was Legena from 2018 that showed that patients with AOBs tend to have a high narrow palate. There's also a difference in anterior-posterior development of the maxilla as well. And this all builds a picture for the anterior open bite case. A narrow maxilla, the upper incisors remain quite high for the patient, but also this changes to the function of the palate due to this presentation, and therefore function is affected. Roberta describes two methods of treatment, an orthodontic approach involving a quad helix for expansion, and an orthopedic approach, and how Roberta manages that is with rapid maxillary expansion to correct the transverse in the maxilla, but also combining it with a lower removable bite block appliance with 5mm blocks to help carry out some intrusion. So how does this biomechanically work? Well, Roberta described how expanding in the maxilla allows spontaneous eruption of the upper incisors. The arch is no longer narrow, there's no vertical obstruction taking place. She mentioned how the expansion can increase the vertical dimensions, and to help control this, the bite blocks are used for the intrusive effect from the lower arch. Now, what's the evidence? Well, in Roberta's study from 2017 in the AAO, they looked at 1 year follow-up of this protocol, expansion with the RME and using bite blocks in AOB cases. And they found there was a significant improvement. The AOB improved by 2mm, the lower anterior face height reduced by 1.5mm. But interestingly, the growth pattern changed as well. There was significant rotation of the mandible in a counterclockwise direction. So what's the stability of this long term? We know lots of orthopedic treatments can get washed out as time goes on. Well, in a 2-year follow-up study by Musadera in 2018, it showed that actually the molars had maintained their position. The overbite was 1.8mm greater than when they had started. So some relapse, but very small. And what's the effects upon RME when it comes to the facial pattern in AOB cases? So Roberta followed that up in a study in 2019. And it was interesting. Looking at a cephalometric study, they found the effects of RME were to increase the posterior mandibular height. The ramus increased in its size. That counterclockwise rotation of the mandible was maintained, and there was a reduction in the steepness of the occlusal plane. I think these are really interesting findings, and I think we're learning more and more about some of the treatments we carry out, specifically rapid maxillary expansion, as it appears to be used more commonly. I look forward to seeing more work from Roberta. It was a great presentation. This lecture is entitled How to Become an In-House Aligner Powerhouse by Jason Cope. So Jason is an innovator within orthodontics and has very much a dedication to the digital workflow process. And at the end of the description, you guys will see a link to find out more information from him and his free available information. Now, Jason described the digital workflow. How does he make this work? Well, there's a number of items that are required, and it starts off with a 3D scanner. Having a workflow management system, he emphasized how important it is to track what's going on. The digital setup, so the movement of teeth taking place. Then carrying out the printing for the digital study models. Then post-printing process to remove the excess liquids of resin that are part of that digital model production process. Then using a thermoforming machine to produce the actual aligner itself. Then aligner material trimming and polishing, and finally aligner packaging. Now, Jason was very honest about his experiences, but also gave insights to how he carries this out. And he showed this in a wonderful way of a view of the plans of his surgery and how it changed with the introduction of the digital process. Essentially, there are some modifications that have taken place, but it's still a similar setup as it was previously with respect to the size and dimensions. Now, Jason went on to describe a case and his experiences with it, a relatively mild crowding case, both upper and lower, and he broke down how he treated the case with respect to the number of appointments, the scans that took place, and delivery. Overall treatment time was about 6 months or so, and his total treatment costs were around $334. Now, he described this as being significantly cheaper than using an external aligner company. He mentioned how blue lab costs, for example, would be around about $1,600 if compared. Now, he said it's not all smooth sailing. With in-house aligner treatment, you're 100% in charge of the setup, whereas if you outsource it, somebody else may do that more complex work or tedious stuff. He mentioned how with in-house aligner planning, you've got to really understand biomechanics and the staging of treatment. Whereas if you get somebody external to do it, they can help out with that process. And you also described how you want to minimize the costs when it comes to in-house, and there's no package option. Whereas if we go for an external company, we can fit it into a package. So I thought Jason Cope gave a really good rundown of how he used it in his practice, and also gives us food for thought. Will it work economically for ourselves? Where is that point where we switch from one to the other? Now, Jason has very kindly left a link for his course and also a handbook to guide people in this process. The link is at the bottom of the description. Please do check it out. This lecture is entitled Carriere 3 Treatment in Minimally Growing Patients. How does it work? This was a keynote lecture by James McNamara. So James described how does a Carriere appliance work? Well, it's a rigid fixation from canine to molar. It involves using a vacuum-formed retainer in the opposing arch and elastics essentially attaching from the upper molar to the lower canine in Class 3 cases. He described the components in detail. So there's a bilateral flexible bonded bar. It's a very stiff form of wire which goes in and is bonded to the teeth. There's a variety of sizes to account for different distances between the canine and the first molar tooth. He described how there's bondable tubes which are then used on the opposing arch, and also then intermaxillary elastics. Now, he described the forces are the key to achieving success, and he uses force 1 on force 2 elastics around about 375 to 500 grams of force. So what's his protocols of implementing using the Carriere appliance? Well, this is how he treats patients. He starts off with records as a convention. He'll then fit the appliance and see them every 6 weeks. He mentions how treatment is usually completed in 6 months. Auditing his own work is 4 to 8 months as a range. Then he completes the case once he's got his sagittal or AP correction with either aligners or fixed appliances. Now he describes some tips. So one of the key tips is to have posterior disocclusion taking place, whether that's through using a vacuum form retainer, using RME or occlusal buildups. He stresses how full-time elastic wear is essential. Now, to the degree he would even ask patients to change their elastics every 4 hours. He gave a top tip about getting patients on board with full-time wear, and it's the 15-minute rule. He tells patients elastics can only come off for 15 minutes, whether it's eating, drinking or break, and therefore they're far more committed to the cause. Now, James has a study on the Carriere appliance, and it's in 2021 it was published. It's a retrospective study, and what he found is that there was no statistical difference when it came to the AP changes. There were some facial changes, and it was an increase in the lower anterior face height by 2.2 millimeters. He mentioned how the main changes are the dental alveolar applications of this appliance. So what were they? Well, the molar relationship improved by around 5 millimeters. When he broke that down, there was mesial movement of the lower molars by around 2 millimeters and distal movement of the upper molars by around 2 millimeters. And his conclusions were that it's mainly a dental alveolar appliance and it can increase the vertical dimensions for the patients. Now, it was great to see somebody like James McNamara doing some research on this topic. As we know, the evidence of a Carey appliance is very limited. Now, although he only presented a retrospective study, hopefully it leads the groundwork to produce more comprehensive studies looking at how this appliance actually works reliably and is it something we should be incorporating into our clinical practice. A lecture which followed on the same topic was the management of the Carriere motion appliance for Class 3 correction in a mixed and permanent dentition. This lecture was by Laurie McNamara McClatchy. So Laurie started off by describing a clinical tip when using the Carriere appliance. Is to ensure the upper first molar is retained within the coverage with the vacuum form retainer. This prevents a distal rotation taking place. Now, she described other side effects that can take place with the Carriere Motion 3 appliance. There can be mobility to the lower canine teeth. She mentioned usually it's fine, but if there's concerns, the patient can stop using the elastics for one visit and it resolves. She also mentioned extrusion of the lower canines. That biomechanical effect of applying a class 3 elastic to the anterior tooth can have a vertical vector of force. And how is this resolved? Well, she says that patients usually go on to a second stage of conventional fixed appliances or aligners, and it resolves at that stage. Or it can be combined with a Carey appliance and an auxiliary arch wire, so having both on at the same time to resolve this extrusion. She mentioned mixed dentition and her protocols for using the Carey appliance in a class 3 case. She starts off with a rapid maxillary expansion using the bonded design by McNamara. Now, this bonded occlusal splint design also allows disocclusion to take place as well. Now, hooks are placed distal at the distal aspects of the rapid maxillary expander. They expand first for about 4 weeks and then fit the Carey appliance after that. And she described a case where the patients had the RME with hooks on. The Carey appliance was then applied to the lower dentition, including a primary canine, and she found that it was fine when it came to being stable. Molar correction took place, and the anterior teeth were not retracted in that particular class 3 case. However, the work around this was to just use some power chain in the lower arch to then retract those anterior teeth. So what I got from Laurie in this particular lecture was the use of the Carey appliance to allow sagittal correction to take place, but actually combining it with fixed appliances to counter the side effects from it. This lecture is entitled Treatment of Maxillary Deficiency with Facemask and Temporary Anchorage Devices by Peter Ngan. Now, Peter started off by describing the prevalence of class 3 cases varies within the population, less so in the American population, greater in the Chinese population. He then went on to look at a paper by Musich in 2020, which was a fantastic paper. Musich looked at his previous treated cases over his career, and the class 3 cases in particular, and looked at, well, why did they need retreatment? Why did treatment fail? It related to 3 components: that of diagnosis, that of growth, and that of treatment strategy. So he started off by addressing diagnosis, and Peter described a functional shift and non-functional shift is key part of our diagnosis. Peter went on to describe growth prediction, which is the mainstay of his lecture. He mentioned how can we predict if patients are going to grow backwards or forwards. We know in conventional terms we usually make a definitive decision between the ages of 14 to 17 once essentially we've seen the growth take place. He mentioned, why is this a challenge? Well, class 3 cases, when they skeletally mature, it's usually later than class 1 cases. That was Reyes' paper from 2006 that showed class 3 cases take a year longer. Also, the duration of puberty takes longer in class 3 cases by approximately 16 months. So when it comes to treating our class 3 cases, how can we predict what's going to happen in the early years? Well, he looked at a paper by Stelzing Einziger from 2002, which showed that if the Witz assessment was -7, it was usually the cutoff for surgery. But Peter went a step further and he looked at, well, what else can we do to predict these cases? And he's developed the growth treatment response vector. Now, what is this? Well, essentially, it's a development on the Witz analysis. It uses 2 cephalograms from 2 time points and essentially looks at the difference at A point, using the Witz A point, on 1 cephalogram and the second cephalogram, and also looking at changes at point B and also that on the second cephalogram. And then that forms the equation. So what happens? Well, what he looks at is simply the difference in change between A point divided by the difference in change between B point. In a class 1 case, it's relatively similar changes. So both maxilla and mandible are not too different, and it's 0.77. Mandible edging ahead of the maxilla. But in class 3 surgical cases, it's 0.38, showing a significant difference in the mandibular growth compared to the maxillary growth. Now, when it comes to looking at a single radiograph and finding a predictor, he described Franchi's paper from 1997. Now, this is where they look at the condylar angle. So to describe the condylar axis angle, it's a line drawn from a cephalogram from condylion. It bisects articulare anterior, and meets the mandibular plane. And if that is less than 147 degrees, patients tend to be fine. If it's greater than that, it tends to be a surgical case. And Suki's paper from 2009 showed that. So what's Peter's treatment strategy? Well, he describes how correction with a face mask is usually in the order of 2.5 millimeters for the overjet. That's Wound's paper from 2017. How do we increase that? How do we make it better? Can we do more things for it? Well, yes, we can. He described the Alt-Ramek principle. So this was from a systematic review by Mohammed Al-Muzian in 2018, where it described essentially expansion using a rapid maxillary expander for 1 week and then constriction for the following week. And it's a 7-week cycle. Essentially, it loosens the circumaxillary sutures greater, allows more anterior-posterior change. He described how this can increase the changes by up to 2 millimeters using protraction face mask. He also described a really interesting idea by Yen in 2011, where they used protraction face mask in the evenings and nighttime, but sectional fixed appliances and class 3 elastics during the day. And the idea that the face mask is pulling the maxilla and the class 3 elastics are holding the maxilla forwards. I thought it was an interesting take on class 3 correction, really looking at predictive factors rather than treatment outcomes, and how that will then help us make our decision for our younger patients. This lecture is entitled Maxillary Expansion and Treatment of Class 3 Malocclusions in the Digital Age. This was by Benedict Wilmes. Benedict started off by describing the side effects for conventional rapid maxillary expansion. We can get mesomigration of posterior teeth, molar extrusion, and tipping off teeth. He then went on to describe temporary anchorage devices and expansion. So he goes, it gives us greater skeletal changes than dental tipping, less mesomigration of molar teeth. It avoids also vertical changes, which is an interesting one. That was a paper by Ngan in 2015. And also greater airway changes as well. That was by Bazaragani in 2017. So he looked at the appliances that have been produced and also has contributed himself with a hybrid Hyrax appliance. Now there is also MARPI, which is mini-screw-assisted rapid palatal expansion. Now there is a subtle difference between these two. He described how MARPI is fitting mini-screw fixtures after the appliance has been designed, was a hybrid Hyrax. The appliance that Benedict Wilmes has formed is the TADs are inserted into the ideal position, followed by design and planning of the appliance to be fitted for expansion. Now, where does he insert his TADs? Well, he described the T-zone, which was from Benedict Wilmes' paper from 2016. And essentially, it's on the palate. It is a T shape around the third palatal rugae, and it's the long access associated with the mid-palatal suture. He described buccal versus palatal and how he has gone more towards the palatal side. That relates to the success rates between the two, of around 98% for palatal TADs, but around 71% for buccal TADs. That was Hofer's paper from 2017. Now, it's interesting is that sometimes we are put off putting TADs in the palate, and I know that's true for me. And sometimes it's because of discomfort to patients. Interestingly, a study has looked at this by Feldman in 2017 and showed that positioning 2 TADs in the palate, patients found was not uncomfortable. What they did find uncomfortable were buccal TADs. And he related this to the loading of the TAD being what caused the discomfort. Now, Benedict's talk was also based on how can this expansion with TADs now be applied using digital planning. So he described his process. It's of 3 things: using CAD-CAM insertion guides for the temporary anchorage devices, digital monitoring of patients, so we can see the changes taking place, and also using a CAD-CAM designed expander. So Benedict produced a paper in 2019 which described this. And the advantages of a CAD-CAM based bone board expansion is that it can all be done in one go. One appointment, TADs go in, appliance is also inserted. He described how it's useful for people with less experience using TADs, as the appliance itself acts as an insertion guide for the TADs. He described how there is detailed planning required, and he used really great visuals to show superimposition of a cephalogram with an STL file from the patient's intraoral scan, and also using CBCT data to locate that ideal bone, so we're gaining predictability. He described dental monitoring. So there's been a Theromon chip study where they looked at what's patient's compliance is like, and he doesn't see monitoring as a form of spying on patients, but more as a way to motivate them, which I thought was an interesting twist on it. Benedict then spoke about Class 3 cases, how he's explored using temporary anchorage devices in the lower arch and also in the upper arch and using Class 3 elastics. But he found there was a high failure rate for young patients with lower labial TADs. He's also looked at using bollard plates, but he found actually the failure rate was quite high. Around about 25% was a publication from Hevele in 2018. And it seems to be bollard plates in the maxilla tend to be ones that fail if they are to fail. So he looked at using combination cases of hybrid TADs and maxillary expansion. Now he described how it works well in the maxilla to allow both skeletal expansion to take place, but also to distalize the molars. And combining that with bollard plates, of bone-anchored maxillary protraction plates, but this time applying them to the mandibular arch for the Class 3 elastics. Now he gave a top tip here for anybody having orthopedic bone-anchored appliances, and that's to leave the mini screws in place for skeletal anchorage, potentially later on for orthodontic treatment, but also in case relapse takes place. He described using RME with palatal TADs only, so not a hybrid appliance. He mentioned how this can be inserted because it's no longer dental borne. Actually, the rate of expansion can now be lower. From 2 turns a day, we can go down to 1 turn a day. And the actual expander he used, he gave the details on. It's an RMX expander, which is pre-formed and can be ordered to be combined with temporary anchorage devices. So in conclusion, CAD/CAM manufacturing expansion. The advantages is that it's precise, there's no bands needed, and it's a customized appliance. It can be placed directly at the same time as the temporary anchorage devices, and there is no play between the TADs and also the appliance itself. I think this is very much a growing topic within orthodontics, and Benedict spoke very well about this and how he clinically applies it. I suppose for me the question which still remains on this topic is, when is it better to use TAD-supported expansion or just sticking to rapid maxillary expansion, which is dentally borne? And I hope to see that evidence and ideas being explored further, so I know clinically where does this component fit in to my clinical practice. This lecture is entitled Clear Aligners in Orthognathic Surgery by Flavio Uribe. Flavio put aligners into where they are in our clinical practice. And there was a really interesting questionnaire done in the Journal of Clinical Orthodontics by Kim in 2020. And it shows that for those people in the questionnaire, the orthodontists, aligners make up 57% of our clinical practice. And that's been increasing massively. Back in 2014, it was 22%. The questionnaire also asked, well, how satisfied are orthodontists with the outcomes? And 90% of them were. What types of cases are treated by aligners now? It seems to be every malocclusionist. So the next stage really is looking at aligners with orthognathic surgery, and that was Flavio's interest. He describes some of the challenges of using aligners. Well, in orthognathic surgery, brackets are typically used as part of intermaxillary fixation. Now with aligners, that's not possible. So what are the workarounds it? Well, there's possibilities of using temporary anchorage devices, but there's always that risk of root damage. There's also a really interesting take on a surgical splint, one that's essentially a positioner or 2 vacuum form retainers joined together. That's by Nkamitini in 2019, and it's a really interesting idea which utilizes both an aligner and retainer, but also as a surgical splint as well. Now, how does Flavio carry out this treatment when it comes to surgery first cases? Well, he described how he'll take scans 2 weeks prior to the surgery and will then fit the aligner 2 weeks after the patient's surgery. And he finds it tends to fit well. Patients usually have the surgical splint in that interim. He describes it's a bit more challenging for cases of segmental maxillary surgery, where patients have a scan 4 to 5 weeks after the surgical splint is removed, with the aligners fitted 4 weeks after that. So there can be a time delay. Now, what are the outcomes of patients having aligners and orthognathic surgery? Does it work? Well, he described 2 particular studies. So one looked at the AAO, looking at the orthognathic outcomes. When it came to Invisalign versus conventional, Invisalign didn't fare as well. This is Roberta's study in 2016, with the AAO scores remaining at 41, showing a fail when it came to the AAO. Now, in Flavio's study, he's looked at his own patients and he found that actually PARS improved massively at 89%, reduced all the way down to 3.5. But when it came to the AAO, which in his opinion was a far stricter criteria, it showed that the average scores were 33 after surgery, so still outside of what would be considered a pass when it came to the AAO. Now, Flavio looked at that in more detail because at this stage I'm thinking it's not possible to do aligners and orthognathic surgery. But he looked at why they failed the AAO, and actually it was because of rotations on the second permanent molars. Something from a biomechanical perspective, aligners really struggled to do anything with the second permanent molars. But actually looking at the cases he presented, the cases were treated really to a very high level if the second molars could be ignored. So maybe that's an acceptance when it comes to treating these cases, or something else we need to plan around. Flavio then showed some of his clinical cases and concluded that actually aligners are well suited to surgery-first cases and something that we should consider going forwards. I enjoyed Flavio's passion, his ideas that he has to take forwards in clinical practice, and he's very much leading the way when it comes to being innovative in his orthodontic treatment. This lecture is entitled Growing and Redirecting the Roots of Impacted Teeth by Stella Chaushu. This was a very well delivered lecture, and Stella asked three main questions. Does the impaction of teeth affect root development? Second question was, can we erupt teeth with impaired root development? And third, can we modify root development by early treatment? So starting off with the first question, does impaction affect root development? Well, the answer is yes, it does. When it comes to the research which Stella has done, it shows that impacted teeth's root length, when it comes to the incisors, is usually shorter by 3 millimeters. For impacted canines, it's usually around 1 millimeter. Interestingly, majority of these teeth will have the average root volume. So the explanation of this is that there's usually a hook or there's a dilaceration which has taken place in the development of these teeth. So the conclusion for the first question is yes, the teeth impaction does result in adverse effects to the root development. The next question was, well, can we erupt teeth with impaired root development? Well, what Stella stated is that the intrinsic properties of a tooth to erupt are still there, and they're unaffected by the root shape. She does mention that the treatment time is longer for these patients, but it's usually related to the displacement of the tooth, not due to the adverse root shape. On average, patients will take around about 4 months or so greater in treatment from her study. And finally, the big question is, can we change the root development of a tooth if it's impacted by early intervention? And the answer to the question is that if we do plan early intervention, we can change the root development. Now, historically, we wouldn't put appliances on patients until they had a significant amount of root development. But actually what Stella challenged us with is the idea of treating patients earlier on to avoid adverse root development. If the patient's roots are only a third developed or even less, ages of 7 to 8, they are amenable then to orthodontic movement, and we could potentially ensure the roots of ideal size and length. Now, I thought this was an interesting topic, but a very well delivered lecture, asking key questions to apply to clinical practice. This lecture is entitled Surgery First, Combined with CAD-CAM Brackets and 3D Predictions by Juan Fernando. So Juan spoke about how surgery first was popularized by Sugarara. Now the idea is patients have their surgery carried out for their skeletal discrepancy, followed by fixed appliances to then correct the remainder of the malocclusion. Now Juan spoke about the advantages of this approach. Patients have changes to their face at the very beginning. They're growing confidence straight away. Whereas conventional carrying out decompensation can actually have negative effects on their aesthetics and also the patient's self-esteem. He described how the rapid acceleratory phenomenon takes place, how it's quicker treatment, and actually average treatment times are approximately 1 year to 15 months for this approach. What are the long-term stability like for patients who have surgery first? Well, this has been looked at. When it comes to transverse stability, there's no significant changes, Anterior open bite and vertical changes are stable after a period of years. That was Leo's study from 2010. Also, AP correction is maintained by a co-study in 2011. Now, there have been a number of systematic reviews looking at surgery first, and two of the key findings that Juan spoke about was which cases do we treat with this approach. It seems to be skeletal 3 cases, at 84% of the cases that have this. That was Mario's study from 2016. Interesting conclusion from a systematic review by Barone in 2021, and it stated that CAD-CAM and virtual setups can help surgeons and orthodontists understand their skeletal discrepancy for surgery first. Now, how is surgery set up? Well, there are a few different approaches to this. Sugawara will have brackets placed prior to surgery and have a heavy wire immediately after surgery, a custom-made wire to allow some intermaxillary fixation. Leo will go for brackets prior to surgery, and the wire is placed 1 week after surgery, so essentially no traction on the teeth during the surgical time. Whereas Juan Fernando's protocol is slightly different. He has a CAD-CAM planning when it comes to bracket and bracket positioning. He has custom torque built in and coordination. The brackets go on just before the surgery, and on the day of surgery, the patient has a light arch wire placed during surgery itself. He spoke about some others will have custom-made wires, so they're passive, but because it's placed on the day of surgery, it's not going to change the planning when it comes to the wafers. Now, he mentioned how skeletal anchorage and elastics can be used from the beginning if self-ligating brackets are used. He spoke about immediate activation, engaging the arch wire. Now, he reviews patients on a weekly basis and then on a 2-weekly basis. And this is what he found from his treatment protocol, is that after the arch wire is inserted on the day, he found that he'd be changing the arch wires at 11-day intervals. His working arch wire would be a 1925 TMA as a final arch wire. And he mentioned the key to this success in the process is the digital planning, the use of CAD-CAM positioning when it came to brackets, but also the use of stereolithography when it came to production of the splints and the templates. There's a paper by Juan Fernando, which is in 2018, which describes a patient going through this journey. It's a very well-written paper, and I do suggest people interested in this approach have a look at his paper. This lecture is entitled Clear Aligner Treatment, One Size Does Not Fit All. This was by Dr. Clark Covale. So Clark started off describing as to where aligners are in the marketplace at this stage. He mentioned how Align technology has grown every quarter. Smile Direct is a $3.2 billion company. And he mentioned how other companies are changing from conventional orthodontics into aligners. He described how Dentsply are stopping the production of orthodontic treatments and have now purchased Byte, a direct-to-consumer company. Expected growth from Dentsply is 25% when it comes to aligners in a year. And he mentioned as to why aligners are growing so much so in the marketplace. There is real innovation taking place in the use of aligners, whether it's through using aligners for anterior-posterior correction, innovations with attachments, and Invisalign's recent G8 is a summation of some of those ideas, but also expansion with aligners using mini-screws. It's being shown to work with other forms of biomechanics to get ideal outcomes, and also looking at phase 1 treatment with Invisalign first. So which aligner system is ideal? Well, what was mentioned by Clark is that there's no one which fits all, the title of his talk. There is patient preferences, there are doctor preferences, and biomechanics which play a difference. He described how patients' preferences relate generally when it comes to timeline and to costs. When it comes to the clinician's preferences, okay, we've got decision making, we can go in-house, we can use an external company, or we can use premium companies such as Invisalign. So he described how he fits this into his clinical practice. He uses in-house aligners when it's usually 1 to 8 aligners. And that's when it's relatively cheap to produce, around about $10 or less. Anything more than that, he didn't see it being economical. When it came to using external companies such as Stars, that's usually when we're looking at 7 to 14 aligners, relatively straightforward cases. Now, when it comes to more complex movements, he's really looking at using things like Invisalign, a force-driven system, one that gives him reliable biomechanics. Clark also made made it clear there are other costs we need to bear in mind. When it comes to using in-house aligners, we may get it back cheap, but patients' preferences are also to receive nice packaging and arrangement, which we also need to factor in when we're choosing our product. He mentioned using outsourced companies such as Stars. They can get aligners back within 3 to 4 days, and it can take longer with other companies. And he mentioned finally how Invisalign is a premium product, but to deliver predictable biomechanics and also to get that premium packaging, it is one which has those components to it. I thought this was an interesting lecture by someone who is associated with Align technology, just breaking down as to how does it work for them, but also being quite honest about the costings of the approach as well. And I think the idea that one size doesn't fit all is one that I'm really taking back from this lecture. Can I now utilize different companies and different components and actually still deliver that reliable outcome for my patients? And I think for me, the idea of where does the patient's preferences come into it is one to also now start to bear in mind in that decision-making process. This lecture is entitled Efficiencies of Aligner Treatment in Teens and Early Treatment. This was by Jonathan Nicozisis. So Jonathan gave a really dynamic lecture where he described his use of Invisalign specifically in his clinical practice. He started off giving the advantages of aligners. He mentioned that there are less appointments required for aligner treatment compared to conventional fixed. It suits patients' lifestyles better. And very specifically in our current circumstances of COVID-19, he mentioned how patients can very easily come pick up their aligners without having to engage in a clinical appointment. Jonathan mentioned the key to aligner treatment in this current environment we live in is the virtual care system. It allows digital monitoring of patients to go through, and actually how we're seeing patients more frequently, although remotely, than we were previously when it came to our clinical assessments. He mentioned the use of GrinScope, which is a digital monitoring software which he uses, and patients send videos of themselves in and then they are assessed as a result. Now, Jonathan described the treatment of patients early on. He mentioned how phase 1 makes up about 10% of his clinical practice. The types of cases he's treating are anterior crossbite, alignment cases, and class 3 correction. Now, Jonathan was very honest and was very keen to share how the things break down when it comes to the finances. So he now describes his phase 1 of being a very lucrative aspect of his clinical practice, earning anywhere between $500 and $1,000 per visit. He gave an example of a clinical case he was treating with fixed appliances. There was some proclination that took place to the lower incisors and gingival thinning. He wanted to gain real control of this case. So he switched to aligners, carried out some controlled arch development, and retracted the lower incisors and intruded them simultaneously. And he mentioned this movement was synergistic with aligners and just wasn't possible to deliver as predictably with fixed appliances. He went on to describe how is it fitting in for him at pricing point when it comes to patients. He described his new outlook when it comes to the product, and that's of unlimited aligners for 5 years for younger patients. He goes, this is really enabling patients to have phase 1 treatment when it's appropriate, and it also allows them to feel comfortable knowing that comprehensive treatment will take place if it's required. It's one lab fee for the clinician, so therefore the savings are all around from a business perspective. He next went on to describe some clinical tips about a canine extrusion case. He mentioned how in conventional appliances we may build anchorage through tip-back bends in class 2 cases, and actually we can do the same with aligners with where we plan for the tooth movement. He mentioned about extruding the canine specifically. Well, what we really want to do is ensure the mechanics are pushing on the tooth. So actually if we move the canine labially first and then extrude the tooth, there's a continuous push on the tooth that's taking place, making things more predictable. And finally, he mentioned if premolar extrusion is required in refinement, that be aware of the reciprocal effects are taking place with molar intrusion. So he mentioned to ensure that posterior leveling is taking place of the occlusal plane. In conclusion, Jonathan said that using aligners has increased the efficiency in his practice of phase 1 treatment and reduced his appointment time with aligners down by 25% with the advent of dental monitoring. I enjoyed Jonathan's lecture. It was very dynamic, he was very honest, and was very clear to say the advantage of using aligners in his clinical practice. This lecture is entitled The How-To Guide of Digital Braces, Teledentistry by Brandon Owen. Brandon has very much established himself as an innovator in orthodontics. He was actually the winner of an award from the American Association of Orthodontics a few years ago as the best innovator in orthodontics. So Brandon was here to really talk about the limitations of conventional appliances, his experiences using digital guided bonding, and then moving on to custom appliances. So the limitations he described with conventional appliances. Well, we aim to get the bracket in the ideal position. However, due to variation in biology and slop within the system of fixed appliances, it does not ensure that we're going to get the ideal position of the tooth. He mentioned how usually there's a challenge with the third order, and that results in both a second and first order discrepancy. We've got some ways to correct it. We can reposition the bracket in the second order sense, or we can use a full-sized arch wire. Now, he urged caution at using a full-sized arch wire. He mentioned how that we are not identifying the underlying problem, and that's the variation in anatomy of the patient. He mentioned how we can create further problems through going to full-sized arch wire, such as a roller coaster effect on the posterior occlusion due to marginal ridge height anatomical discrepancies as well. So then he spoke about digital guided bonding. He mentioned how we can ensure we get the bracket into the ideal position. However, this still has a limitation. It doesn't account for variation in anatomy. It's not customized for the patient, more though it's customized to get the bracket into the right place. He drew an analogy of aligners, and I thought it was a great one, how aligners, if they were restricted to just an MBT or Roth, etc. prescription, they wouldn't be able to achieve the outcomes that they do today. Brandon went back in time and spoke about the golden era of braces, the 1980s, where we had nickel titanium arch wires which came into being, we had bonding which progressed, but also bracket prescriptions. And he described out of these three, bracket prescriptions were the biggest innovation of the time. They increased the quality of outcomes and increased efficiency. He then went on to look at the literature and showed some studies that compared customized appliances to conventional appliances. And overall, there was a reduction in the amount of clinical time taken for these appointments, also a reduction in the number of appointments by 40%, and also, and most crucially, the clinical outcomes were superior, with the AAO coming in at 20% better. That was Weber's study. So he mentioned, well, why haven't we had a revolution in digital orthodontics? Why hasn't it taken over? And he was very honest about this and said that the cost is one of the biggest factors. We have to save at least 6 appointments to break even. There's a delay. It takes a while to produce the product. And historically, the transfer trays weren't great. So if they didn't fit well, we essentially lost the advantage of being customized. He then spoke about utilizing digital bonding for patients and also customizing the brackets. And he mentioned his protocol for doing it. He starts off by looking at the torque to begin with. I thought it was really interesting. He starts with a third order. And he mentioned if we can get this correct from the beginning, we can easily modify the first and second order. He incorporates, on occasion, the cone beam CT into his planning. So how does that work? Well, he may have a plan to move the teeth into the ideal position, but now he's going to look at the anatomical factors for that. Are his biomechanics biologically achievable? And I thought that was a really clear and succinct advantage of this process. Brandon advised that when using custom treatment, it really should be an orthodontist who's doing the work, for we know the biological limitations, but also biomechanics and their limitations as well. He described there has been advantages in the use of different resins to make things far more accurate. And then he finally concluded by describing remote monitoring and how this has now allowed the assessment of patients to take place more regularly, although in a remote sense. And he mentioned how patients will take a scan 1 week before attending, so he can already plan what's going to take place in that clinical appointment. And he finally concluded that if you put the right brace in the right place, that is how you get the case to treat itself. And that is through using digital bonding and planning for our clinical cases. That brings us to the end of this podcast and day 2 of the AAO. I thought it was a very different day to day 1, where the focus here was really looking at class 3 cases. looking really at digital orthodontics. How have the innovators implemented it clinically? What are the changes that have happened so far? Where are we today? And I think it's an exciting aspect of our profession, how we are integrating it. It was a really interesting statistic, is that the biggest 3D printer across all sectors beyond dentistry is actually Invisalign. So it shows that we are very much leading the way in the development of some of these components of technology. And I'll conclude with a quote from Brendan Owen: "We may not be in the golden era of orthodontics, we may well be in the platinum era." Hope you've enjoyed this episode. Please do subscribe and look forward to day 3 coming out next week. And also, if you want to see the notes, please look at the description and you'll see each individual episode there.